So starting off, we have our first speaker, Dr. Challa Divya Reddy, who's a faculty cornea services at LV Prasad. And she is going to be talking on challenges in corneal ulcer management, infection or imposter. On to you, Dr. Divya.
Good evening, everyone. Welcome to today's Tough Nuts to Cracking Cornea. Today, I'm going to present a case, and also I have to give a case courtesy to Dr. Dupesh and Dr. Anba for this. So this is a case where a 41-year-old female hailing from Madhya Pradesh presented to us with left eye redness, watering, and diminution of vision since 5 months. There is no history of trauma, but she has a history of multiple ophthalmic consultations done locally, and where she was treated as viral keratitis and given oral acyclovir and also started on topical steroids. In another consultation, she was diagnosed as a fungal corneal ulcer and also started on antifungals, and steroids were also continued. So when she came to us, this was her ocular examination. The right eye was unremarkable. And coming to the left eye, there were a mild lid edema. And this is her slit lamp picture, where we could see that there is a central well circumscribed 3 into 3 mm mid-deep stromal infiltrate, and there is a surrounding edema, and a large mutton fat capes are also present on endothelium. And there was no AC cells. So where the same findings could be seen on the anterior segment OCT, the infiltrate involving the deep stromal with corneal edema and underlying mutton fat capes upon to the endothelium could be seen. As there is no epithelial defect or no material to scrape, we went ahead and did a confocal microscopy. But on confocal microscopy also there was no organism, no clear-cut organism that could be revealed. But there was a pinpoint lesions that can be seen, which is somewhat suspecting of a microsporidia. We went ahead and posted her for corneal biopsy. So a triangular shaped flap has been made and underlying scraping material has been taken, and also a small amount of tissue has also been taken to send it for a histopathological examination. So this is the post-operative day 1 picture after the corneal biopsy has been done. The biopsy material has been sent for the scraping. So on scraping, on KOH, grams and acid first, it has came out to be a microsporidia spores, and PCR is also positive for microsporidial DNA. So she was started on Mozol, Homide and Quigilin eye drops, which were prepared in our pharmacy, and also given a systemic oral albendazole of 400 mg BD. This systemic albendazole has been given for a period of 4 weeks. This is a post-operative 3 weeks where we could see that the edema has been started decreasing and also the infiltrate size. So the same medication has been continued, and on top of that, topical steroids has been added as deep stromal microsporiditis will have a cellularity without ulceration and will have a good progress with good response with the topical steroids. So this is the post-operative 2 months where the infiltrate size has been slowly consolidating and the edema has also been decreasing. So she was continued with the same medication. And this is over a follow-up period of 4 months and 5 months. And her last follow-up was 5 months where the medications has been continued and lotipred has been advised for about 1 month. And she has regained a best corrected visual acuity of 20/30. So this is the case.
Thank you, Dr. Divya, for showing a very nice, rare case. And yes, Shreyas.
Oh, wonderful case, Dr. Divya. And, I mean, any stromal microsporidiosis is not an easy condition to treat. Just to, set some context, in such a situation where you had a central infiltrate with so many surrounded mutton fat capes, was there a trial of treatment before you went ahead with the corneal biopsy, or right away you went ahead with the corneal biopsy?
Right, and we had with a corneal biopsy. We did the confocal and then the corneal biopsy in the next day.
Proceeded with the corneal biopsy based on the confocal findings.
Yes.
Wonderful. First question, Radhika madam. I mean, very often Stromal microsporidiosis doesn't, respond to treatment, and of course, very long course of treatment, like Dr. Divya already showed. Would you have had any different approach at the very onset of this clinical picture?
So I think this case underscores, a lot of overt and subtle points. I think the first learning point in retrospect is any fungal keratitis or viral keratitis that refuses to abate or go away for months together is, supposed to raise a suspicion of stromal keratitis, because viral, the pattern is waxing and waning, and fungal, the pattern is either it resolves or it worsens. So this is something which lies indolent. So I think the pointers here would be, Divya, if you could go back to the clinical picture, the fluffy nature of the infiltrate, the white appearance, the lack of epithelial defect in spite of having a significant infiltrate. I think these are the pointers which, make us suspect of this particular entity, along with the history of, prolonged duration. So to put things in perspective, the diagnosis of stromal microsporidiosis becomes high. Clinical appearance and the history given. I think the biopsy is a must, because I think the patient was treated elsewhere on various lines before they came here. My tenet is either you must get clinical improvement or you must know what bug is causing it, preferably both. But if you don't know the organism and if you don't have an improvement, I think it is time to set the ball rolling to do something. So the trapdoor biopsy is a very nice approach. I also adopt it, though I make a triangular flap, because if you just dig into the cornea, you're only going to, risk a perforation of some sort or not get enough material. I'm not very happy with the harvest with the needle biopsy. So here you can go into the exact plane where you see the infiltrate and you can scrape out some. And if perforation is threatened, you can just put the flap back and suture. So it is a very good approach. Medical treatment wise, I agree with you, Shreyas, that both literature and personal experience say that stromal microsporidiosis TPK, has to be done. But I think Bhupesh has collected a series whereby he has procured fumagillin, which is not available easily in our country. And over a long period of treatment, he has shown some benefit. But the only plus side to this disease when you do therapeutic PK is two things. One is quite often it doesn't recur. I feel if it recurs, it's not because of the organism, because the patient has gone and bathed the same pond or whatever. He's gotten exposed to the same source. And stromal microsporidiosis is a condition where post-operatively, post-CPK, you can start steroids immediately. You can salvage the graft for vision as well.
Would you, Nikhil sir, I mean, I know you also have a great depth of understanding, knowledge in infections, and
Yeah.
microsporidiosis, obviously, all surgeons would have only a handful of cases which they've treated successfully. So
Yeah.
your thoughts on this and anything different?
So I think Dr. Radhika has said most of the things. Just a few things that I would like to say is that one, like this patient had a very central infection. We have taken a wedge of tissue from the center and we are treating him for 6 months. So the other way of looking at it is that if he is going to end up in a dense scar and eventually need a PK, why not do it maybe at an earlier stage when the, instead of trying to linger on with the medical treatment? Because one of the problem is that when you give steroids, sometimes, the disease might look quiet, the eye may look quiet, but you can see that even at 5 months, we are still with fumagillin and these type of things still going on, and lotepred also. So of course it depends. If this patient has good compliance, you can wait and then let it scar and then maybe try contact lens and things like that. But with such a bang center scar, I think you will eventually need a PK. So maybe in practice, sometimes we may not have situations where patients will come to us for 6 months. They will either lose faith or they'll disappear. Maybe with the institute they can still manage. But I would have considered, because there is enough margin all around, so you could do a very good optical surgery and remove at least with a good 1 millimeter margin. Still you may be at 7 or 7.5, 8 millimeter. That could be one of the options, but I think they have a nice case. And the other thing, I'm not sure whether one should give steroid or wait for, because anyway there's going to be scarring. So we are just giving steroid to suppress inflammation, but it can also, as she said, try to mask the signs of active infection and just delay the course of the disease. So it's like maybe let it heal quickly, or instead of giving steroid and lingering longer and longer. I don't know. I mean, Dr. Bhupesh has tremendous experience. So I think maybe that may be the way they go. But this is just one of the alternatives I thought of.
what about the recurrence which can happen on that graft, and what special precautions should be taken if you think so?
So basically, if you have a very large size of ulcer, then of course you're worried about recurrence. Although in microsporidia, at least beyond LVP, I don't think other than a therapeutic PK is what people are doing, because we don't have access to these drops, and these drops also take several months, as we saw, to get recovered. So like in this patient, there is a very central ulcer, so you can easily cut across maybe a 1 millimeter or even larger rim, and once you have removed the entire infected tissue, the chances of recurrence are remote, at least in this case. If you have very advanced cases, then it's tricky, and there could be a possibility that we may have recurrence, definitely. The other option, we don't have many other options in this particular infection, actually.
Usually recurrence is rare, like Dr. Nikhil said, unless it's a large ulcer. Unlike fungus, where recurrence is more common. Usually the patient is exposed to the same source, and that is why it comes back. Divya, I was just curious to know, did you say that you actually saw the spores on confocal? I'm finding that a little hard to understand, because they're too tiny compared to acanthamoeba spores.
Yes.
And could you actually pick it out on confocal? That's
Exactly, it
interesting.
was not when we did the confocal, but when we retrospectively found the microsporidia on the KOH and Gram-stain, then we went back and went searching. There
Correlated
is
something.
some more, something retrospectively, which I found some tiny dots, but not exact rosette type of kinds which we can see in the microsporidia. That was not there on confocal.
I mean, Dr. Divya, you know more about this case than any
Dr.
of us.
Himanshu has to add something, and
Yeah,
then we'll have to
sure,
move
sure,
on to our
sure,
next speaker.
sure.
Sorry. Yeah. So I was just telling that fumagillin works theoretically. That's fine. We don't have availability, but we have treated, and most of us, and anecdotally, would have treated, and we have treated fortunately, few cases where we have treated with albendazole. We have treated along with the topical voriconazole, and the lesion did disappear. One of the bilateral case, I think we've just published recently. Bilateral case also we treated similar way. So fumagillin available, of course, I would love to start, but if it's not available, that's not end of the road. We surely can try out rest of the things which are available, and
Yeah. Thank you. Thank you very much, Dr. Himanshu.
I have a
them
comment.
do
Yeah, yes,
respond.
Dr. Amit.
I mean, we don't see too much of microsporidia in this presentation. Definitely, we have not seen in Chandigarh, north of India, because of the weather, the climate, or environment, or whatever. But we are fairly bullish about doing a PCR. I don't know what the panel feels about it. Like we have a, pan-bacterial fungal PCR and viral PCR, and we do have PCR for microsporidia as well. So before going in for that, I would certainly have taken a PCR sample. It's very simple to take an aqueous sample and send it. And as Himanshu said, I do like to give albendazole in these patients with this kind of a history coming in. I think Divya, you did a great diagnosis. It was fantastic the way this case was diagnosed. And I'm not sure whether you checked the corneal sensations. You didn't mention, because if it's a viral stromal kind of, which it looked, it would have a decreased corneal sensation. So excellent case, but my take would be maybe do a PCR first and then carry it forward.
Thanks a lot for